Thank you, Dr. Koech. You can hear me? Thank you, Dr. Koech, for those kind words of introduction. I appreciate. Thank you very much to the organizers for the conference, even for the invitation to come and share on this key topic in care of our renal patients. I greatly appreciate. Indeed, the sessions I have attended before, they've been quite helpful and useful. So the burden of CKD is rising in our country and worldwide, and there's a rising need for renal replacement therapy. With most of this renal replacement therapy being in terms of hemodialysis. Very little peritoneal dialysis going on. Transplant programs are coming up, but we must agree that the greatest burden and most patients are opting due to various factors and reasons to do hemodialysis. And most of the patients, and so this has led to a sharp rise in the hemodialysis units. A paper done in Nigeria in 2000 showed, for example, in Kenya in 2000, the population of patients who are on hemodialysis was only 220. Currently, as we speak, in Kenya, we have more than 4,000 people on hemodialysis. In 2000, the providers for hemodialysis were 7. Currently in Kenya, we have more than 200 providers. These are both hospitals, private hospitals, faith-based hospitals, standalone institutions, private institutions. So indeed, the numbers have swollen over a very short time. And while we celebrate the new units, which definitely have been beneficial to the many patients who are attending the services, there are new challenges. There are new challenges of supervision, guidelines, regulations, and all these factors, they affect the outcomes in the hemodialysis units. So in the new units, who is supervising the care that is being given? Currently, we have very few nephrologists, not only in Kenya, but also in sub-Saharan Africa. So who is able to supervise these units? Many units have been, don't have clear guidelines on how to carry out the services that they do for the patients there. So who develops the guidelines? How do we go about it? Kenya Renal Association has done a lot of work in this area of developing guidelines to assist in the services that are being offered in the dialysis units. How does the regulation go about for the many hemodialysis centers? Some of the centers have been opened by people who are not even medical people, but business people who see it as a business opportunity. So who is regulating these people? So all these factors, they are going to affect the outcomes. So as a country and maybe as a continent and the world, as we think about the outcomes in this great rise of number of patients who need care, many units that need to be guided and supervised, then we have to think about the measures of quality, or what are the key performance indicators that can be observed in a unit to to give the information that actually this renal unit is running and offering a quality service. The key performance indicators have various roles. One is that they ensure the safety of the patients that are being attended there. They also ensure the safety of the staff that are attending the patient there. The key performance indicators in some areas influence and help a third party or even its own unit to decide on the success. Because if various indicators were set at the beginning of the year or the beginning of a 3-year program, how we fulfill that affects the success of a unit. In some countries, payments and reimbursements of the dialysis services is tagged on reaching and meeting certain key performance indicators. So whose role is to set the key performance indicators? It is not very clear. There are various people who could set: the patient, the provider of the hemodialysis, or even the government regulatory authorities. So when these 3 people come together, then the country or a society or even a unit can be able to develop key performance indicators that meet the goals and the needs of these 3 people. However, as these key performance indicators are developed, does one shoe fit all? For example, if we say that most patients must be done dialysis on arteriovenous fistula, there's a time that will come, maybe there's a patient who has a stage, an advanced malignancy with a short expected life expectancy, and they may not be an appropriate candidate for AV fistula fashioning. So they may be, it may be more appropriate for them to dialyze with a long-term tunneled dialysis catheter. So should such a unit be judged as having not met the key performance indicator? The answer should be no. While most of the other patients, we should expect them to have the AV fistulas. Maybe this patient, because of this particular patient, the key performance indicator can be changed a bit. There has been many types of key performance indicators like operation indicators, business indicators, or business stroke financial, and there are also clinical indicators. In my talk, I'll try and focus more on the clinical indicators. There have been very many of these, and I cannot be able to cover all of them, from anemia, hypertension, control access, infections, transplantation, mortality. In fact, there's a form I was looking here for a unit, and the indicators for quality metrics were so many, including iron status, calcium, parathyroid, infections, thrombosis, vascular access patency, transplantations. So these indicators can be varied, and they can vary from center to center. I choose to focus on a few. Vascular access is the Achilles heel of hemodialysis. AV fistula, AV graft, and central venous catheters are the mainstay of access. And vascular access complications are leading cause of morbidity in the hemodialysis unit and lead to very high healthcare costs. So AVF provides the best access in terms of longevity and lowest association with morbidity and mortality. And an article here published by K. Digo was showing that per patient per year expenditures, the catheter access was the most expensive, and the AV fistula for the hemodialysis was the cheapest. Various centers have tried to come up with various indicators for their performance in terms of vascular access. For example, in India, they would, their target would be to do an AV fistula first, for the patient who is starting dialysis for the first time, they would want to meet a target of 65%. However, in the long term, they would target to have 90% of their patients on AV fistula. On ANZA data, they would target 43% for the fistula, and they would want in the long term that 86% of the patient have to be using AV fistula. So this data has been changing, and various centers have various targets. The question is, for your unit or here as a country, what could we set as our key performance indicator so that we encourage many of our patients, just like in the campaign Fistula First? How do we increase our patients to start on AV fistula, and what target do we set, and how soon do we adjust that target so that we have more and more patients on the AV fistulas as is the best access? So that is a key indicator in a hemodialysis center. Poor access, of course, leads to poor quality of dialysis, morbidity, high cost, infections, and even mortality. Anemia, this is a topic that has been covered with multifactorial causes associated with morbidity, mortality, reduced quality of life, and reduced physical activity. A paper published by Robinson on anemia and mortality in hemodialysis patients, there was associations of a HB of greater than 11 grams per deciliter with longer survival among maintenance hemodialysis patients. So good HB and reaching the recommended target is a key indicator. Another paper showed that patient mortality and hospitalization risks were 10 to 12% lower for every 1 gram rise in a certain facility. This was on DOPS study. So on Medicare reimbursement, when it was assessed, it was shown that only 10% of patients did not have treatment for anemia. And on a good note, on Medicare payments is that in 1991, if you compare the HB, the average HB in 1991 was ranging around 8.7. Sorry, was ranging around 9. But in 2002, the HB target was 11.7. It was almost reaching 12. So this is a good indicator of improved care in those hemodialysis centers. So units, even in our country and other countries in the sub-Saharan Africa, we need to set a target of the HB that we hope our patients should reach. And should we find that many patients are not reaching that target, then that would be a sign of failing to meet the key performance indicators, and measures can be taken on how to improve. Dialysis water is another key indicator, performance indicator. This is because the dialysis patients are receiving very large volumes of water. They have very poor renal excretion capabilities. 3 areas that needs to be checked is the chemical, microbiological, and endotoxin purity. Several studies have demonstrated that Many times, dialysis fluids and dialysis water is a neglected problem. And water quality and complications of hemodialysis have been known and associated for a long time. Some of the short-term effects include pyrogenic reactions, septicemia. Some of the long-term effects include amyloidosis, malnutrition, and atherosclerosis. This is even a greater concern of water quality and purity as more centers start considering online hemodiafiltration, where large volumes of water has to be infused directly to the patient. Then the issue of water quality cannot be overemphasized. Several associations have come up with the standards, recommendations of various standards, and we can see like the AAMI recommendations and EDTA recommendations is to have less than 100 colony forming units per microorganisms for standard dialysis, and less than 0.25 endotoxin units per mL. When we come to online dialysis, the standards are even more strict. You can even see the AMI recommendations of endotoxins is less than 0.03, so very little. Initially, for the standard hemodialysis, the water should be tested twice. And then after that, if it meets the standards, it should be tested monthly. For online hemodiafiltration should be tested for 3 consecutive weeks to confirm the quality, and then later monthly. Another key performance indicator is blood pressure and volume control. This is critical for patient symptoms, quality of life, and cardiovascular complications. The prevalence of hypertension in hemodialysis units is 70 to 80%. And unfortunately, this is responsible for the high cardiovascular risks associated with hemodialysis. There's a U-shaped relationship between blood pressure and mortality in the dialysis unit, with blood pressure below, systolic blood pressure below 110 and above 180 associated with higher mortality. So the best BP is the gold standard is the ambulatory blood pressure. While there has not been on a complete agreement on the targets, the ideal goal seems to be a systolic higher than 110 and a diastolic less than 150. Another key performance indicator is dialysis adequacy, which previously used to be defined as prescribing and delivering a dialysis dose that is associated with the best long-term outcome. This would be defined by small solute removal like urea, and it would be calculated with KT/V and urea reduction ratio. And in large observational studies, mortality was higher for single pool KTV of less than 1.2, and this would be assessed monthly, and dialysis prescription would be adjusted accordingly. However, dialysis adequacy is more than solute removal, and there are factors that are directly affected by dialysis, treatment and dialysis unit care, like of course the solute, small solute removal, electrolyte concentration, anemia, a bit of blood pressure, but there are other factors not directly affected by dialysis treatment or the dialysis unit care, like the comorbidities, nutrition, protein and calorie intake, medication adherence. So in a recent KDIGO conference report on dialysis, there is a consensus, though not with everybody, that dialysis adequacy is more than solute removal, and it takes factor of many other factors. And one shoe does not fit all. There are more than just one measure that can be used to assess dialysis adequacy. So there could be multiple measures and there could be multiple goals. So the dialysis should be moving from dialysis adequacy to goal-directed dialysis, of which it addresses first and foremost the small solute removal, volume status, residual renal function, biochemical measures, nutritional measures, cardiovascular functions, activity level, symptom burden, and patient experiences and goals. They should be incorporated into the goals of the hemodialysis that is being done. Finally, nutrition is a major player in the morbidity and mortality in hemodialysis. Many parameters have been used, including body mass index, modified subjective global assessment, serum albumin, creatinine, normalized protein catabolic rate. There are many that have been done, that can be done. And mortality risk in hemodialysis patients and changes in nutritional indicators from the DOPS data that was carried on about 7,000 hemodialysis patients in over 140 centers showed that the BMI affected the mortality with the patients with low BMI, like this one of less than 21.1, having the highest relative risk of mortality, with the reference range being done at the BMI of 28.1. And while this was repeated after 6 months change, still the patients who had the greatest change in the BMI, that is the 3.5, as compared to those who gained the weight, who gained in their BMI, they had the greatest relative risk for mortality. Albumin, though, can be influenced by many other factors like infection and inflammation. It is also a marker of nutrition, and patients who had very low albumin had the greatest relative risk of mortality. And after 6 month assessment, the patients who had the greatest negative change in the albumin also had the greatest mortality. So good nutrition is key, and there's a concept of reverse epidemiology, that the patients with a higher BMI had lower risk of mortality. While we understand several of these measures can be affected, like albumin, by other aspects, it would be good to use multiple parameters as a hemodialysis unit to assess the nutrition and the performance of the patients in the unit. So recently, there was a systematic review of various strategies of translating knowledge of best practice into improving quality of renal replacement therapy care. And it was good to note that there were quite a number of studies and efforts to improve the care. And I think this is also an area we should also aspire to keep improving the care for the hemodialysis patients. In the Kenyan scenario, many guidelines have been developed from the Kenya Renal Association. And This has gone a long way in improving the care. There have been guidelines on setting up renal units, guidelines on anemia, guidelines on hypertension control, guidelines on infection control. These have been very useful for improving the quality of the hemodialysis centers. There's a new effort to improve the care, and there's a joint hemodialysis center inspection tool being developed by the Kenya Renal Association and the Medical Practitioners Council. This will be a tool that will address various aspects of hemodialysis unit, and this will go a long way in improving the care in the centers. So in conclusion, there has been a sharp rise in the hemodialysis units, which is beneficial. However, there's need for KPIs to enhance quality. I've looked at a few of them, but from the initial slide is that there are many KPIs that can be made by a unit or a country, and they can be individualized per center and the needs that are there. The KPIs need to involve the patient, the provider, and the regulatory authorities. And I think in the country, there has been a lot of input from the three of these. There are several guidelines which are developed by KRA, and various units, especially in Kenya, should have a look at them and see how best they can implement those guidelines in their units. And implementation of the KRA dialysis inspection tool will be important in offering and improving the quality and the KPIs in our units. Thank you.
Thank you very much, Dr. Njogu. That's an excellent presentation. I can see there is already one question. So someone is asking, how come, just comment more about the reverse epidemiology. How come that higher BMI has an advantage in terms of the outcome, perhaps even in terms of mortality in dialysis patients? Respond to that, and then alongside that, just also comment on, as part of improving the quality or the outcomes in dialysis patients in dialysis units, comment about the availability of a trained renal nutritionist in every dialysis unit, because we see a lot of very simple messages that come along. For instance, patients come and tell you, be told they must only eat cabbage, they must only, just comment about the availability of nutritionists alongside the earlier question, and then we probably will move on later on with other questions. Welcome.
Okay. Thank you, Dr. Koech. Nutrition, as I have said, is a key player. It's a key player on the morbidity and mortality of patients in the dialysis unit. One of the things about high BMI, where is that slide? It's an interesting fact, although I may not have the complete data, whether the lower BMI is associated with more catabolism. The other thing is that due to some nutritional, the whole dialysis process itself, it's more of a catabolic state where the patients have to go through, like in terms of inflammation, the blood is going through the tubes and all that. And also the dietary advice that the patients tend to receive. For example, in many units, you find many patients have been put on very, very restrictive diets. This is mainly maybe to address the issue of phosphate, calcium, maybe to address the issue of sugar in patients who have diabetes. So you find the patients are not getting the recommended protein intake. They're not getting the recommended calories intake. And in the end, they end up falling into malnutrition. And eventually, due to the malnutrition, they get reduction in their immunity, which is also reduced by the whole CKD process. Then they are liable to infections and other diseases that increase their mortality. A nutritionist and a trained dietitian is a key person. And I think even in the recommended dialysis inspection tool, hopefully the KRA will recommend the attachment or the presence of a nutritionist, because many patients are not getting the recommended diets, or they get diets that are extremely restrictive, so that they just affect their basic expected nutrition. So I concur with you, Dr. Koech, that a trained nutritionist is a key and a part and parcel of hemodialysis patient care, and even provision of key performance indicator.
Dr. Koech, can you allow me to comment?
Dr. Toir, go ahead and comment on that as well.
Okay, regarding the renal nutritionist, unfortunately, we don't have enough trained renal nutritionists in this country, and many units are utilizing just normal nutritionists. Unfortunately, with that, a lot of patients, as you've correctly mentioned, get misadvised. So for now, the Kenya Renal Association is recommending that nutritional advice for now must come from the nephrologists, from the physician in charge of the unit, and from the nurses, because we know what our patients are going through. We know that patients are over-restricting themselves. We know that those patients who come and they're very lean tend to not survive very long in our dialysis units. And the patients who are actually obese, with the reverse epidemiology, tend to live longer. And the only way I can explain this is, if you eat better in dialysis, obviously you live longer, because dialysis not only clears your toxins, but also clears the useful micronutrients in your body. So to me, I feel that the more you eat, the better. So for my patients, I give them a simple advice: cut down on your potassium foods. If you're diabetic, cut down on your refined sugars, but eat everything. Avoid high potassium diets. These are avocados, bananas. Avoid madafu because it has a lot of potassium. Cut down on your salt. Restrict your water intake. These are basics, and they go a long way in helping nearly 90% of the patients. The other 10% of the patients that require extra advice, you as in charge of your unit must sit down with these patients. Now, there might be 1% of the patients who need to be followed up by a renal nutritionist. I think then, because as the physician or nephrologist, not because you don't know, because these patients need time to accept this advice, then you can refer them to a renal nutritionist who you've interacted with and who you will know will give the correct nutritional advice. So in the current checklist, we've not said it's a must to have a renal nutritionist, but we've said this is an important aspect, but the responsibility falls upon the nephrologist and physician in charge. Then the other comment I want to mention, Dr. Njogu mentioned that, okay, so the other point that I needed to mention is the standards. So although Dr. Njogu, you said we should individualize the key performance indicators in the units, I think there should be at least minimal quality standards that must be met by all units, such that if I'm dialyzing at Nairobi Hospital, the care that I'll get, for example, the KT/V, the URR that I'll get will be the same as I'll get if I dialyze in Mandera. So just because I'm dialyzing in Mandera, you can't say that we'll allow you to get substandard dialysis in Mandera because you're from Mandera. There's some things that are not negotiable. And I think we need to be strict we need to stick to high standards so that we can compete with any unit in the world. That's my input. Thank you very much for allowing me to comment, Dr. Koech.